So it is a great pleasure to me to introduce Fabio. He's, I think, well known in the domain, but I should present him. So he's a board certified specialist in veterinary and general medicine, and he works in at Anucura in Portoni Rossi.
Yes.
My Italian is good. That's
Very
great.
good.
So in Bologna, and
Better
also
than my friend.
he is also the president of the European Society for Comparative Gastroenterology, and we are so really happy to host you today. And the presentation of Fabio, it will focus it on fecal microbiota transplantation, and there is a lot of results. Hope that this first meeting, it will be not the last for you, Fabio.
Yes, let's hope it won't be the last. It will depend on you and how you receive me. Okay, so it's an honor to be here. So I want to thank you, Juan, and thank you, Moez, for inviting me. It's my first time here at IBD Day, but I must say, I told you already personally, it's been inspiring. Lots of info. You probably, like me, have headache with all the information that we absorbed today. And it's a pleasure to close the day talking about something that is something I'm very passionate about. And it's probably the reason why you invited me to talk about this, which is fecal microbiota transplantation. So the title asks us, in the context of chronic enteropathy, where we stand with FMT. So I'm going to turn the question to you, okay, before we start. Now, careful how you answer, because if you answer, I don't care, then I'm obliged to walk away. So please, so be mindful. So where do you stand? So it's a survey. So you just need to raise your hand. I'll give you some optional answer. Okay, and then we just show a raise of hands, okay? So what's your opinion on FMT in chronic enteropathy? You think it has no place based on the evidence? Raise your hand if you're skeptical. I'm holding still, can you see? So you won't kick me out anyway. So no hands raised, good. Are you uncertain? Raise your hand if you're not entirely sure. Maybe yes, maybe not. There's two hands here. Everybody else is like, I'm waiting for my answer. So the next answer is yes. So you believe in FMT. Well, it's not done. There's a fourth option. So keep your hands up. The yeses, yeah. But there's a better answer, which is hell yeah. And I'm the one who would say, hell yeah. I truly, truly, truly believe, and I want to show you today that there is a place for FMT in chronic enteropathy. So let's remind ourselves what FMT is. This is one of the definitions that you'll probably find most commonly used in the literature. We can read it together. So it's basically transferring or infusing fecal matter from a healthy donor into the gastrointestinal tract of a recipient. This is a sentence we need to be careful about. We will discuss it during the talk. To introduce or re-establish a stable microbial community in order to treat a dysbiosis-related diseases. It's quite an ambitious statement, okay? So we will see that it's probably not necessarily realistic as a target of treatments. This is a new, more recent definition, actually comes from the veterinary literature. So I stole it from Linda Torreson. She's a gastroenterologist. If you don't know her, she works in Sweden and she does a lot of FMT. And in one of her papers, she actually describes FMT as the transfer of the intestinal microbiome, the intestinal metabolome from a healthy donor to a diseased recipient to decrease clinical activity, disease activity, okay? So it's shifting the focus on clinical response and improve dysbiosis, not treat, not cure. And this is probably, we will see, the more realistic target, in my opinion, if we consider chronic enteropathy, especially the cases I tend to see and apply FMT on. I don't know whether you've you're familiar and you're happy with this definition. You probably know that FMT has been used in people for many years, and there are some clinical guidelines published from the American Association of Gastroenterologists, and they confirm that this is the major application for FMT in people. So it's to treat a recurrent or antibiotic-resistant C. difficile infection. This is a major problem, health problem in people. In several populations, even the pediatric population, it's a hospital-acquired condition. So these patients acquire C. diff during hospitalization and during antibiotic treatment. Okay, so antibiotic treatment is a risk factor, and it has a very high rate of relapse and high rates of antimicrobial resistance. And now we know that it's already universally accepted that more than 95% of these cases will respond to fecal microbiota transplantation. Okay, and the FDA recently approved 2 products to prevent the recurrence of C. difficile infection in people. Okay, so it's quite a milestone achievement. And in people, there are many ongoing trials testing the efficacy of FMT in several chronic non-transmissible, I heard this definition today, diseases, not just within the gastrointestinal tract, but also outside of the gastrointestinal tract. And of course, they are testing the efficacy of FMT in IBD, specifically ulcerative colitis. But what about FMT in chronic enteropathy in dogs? Because this is the topic of my talk. You're probably aware that there is some evidence in the literature, not talking about practical experience, the literature, scientific evidence, therefore, of clinical response. Okay, but when you look at the quality of the evidence that we have, unfortunately, it's not very robust, which doesn't mean that FMT doesn't work. Otherwise, I wouldn't be here. But it means that it's mostly done by retrospective study, underpowered studies. They're mostly uncontrolled studies. Therefore, it's very difficult to assess the true efficacy of FMT. There's lack of standardization in these studies, and all the treatments are allowed. So it's very difficult to be precise on what FMT is actually doing in those cases. And you see there is no evidence of improvement of dysbiosis in the studies that you'll find, with the exceptions of a couple of more recent studies that we will see in a second. And the follow-up is very short. Okay, the majority of cases 2 weeks, 2 to 4 weeks. Okay, and you probably agree with me that this is not sufficient to advocate the use of FMT in large scale, and it's probably why in the most recent consensus statement of the ACVIM on chronic enteropathy, when it comes to FMT, you'll find just a little sentence, okay, which says there might be a place for FMT, but we don't know, which is quite disappointing. But I'm pretty sure that the new version will have more evidence. So there was a randomized placebo-controlled trial, actually, published a few years ago from the University of Ontario in Canada. And so it's, again, a small study, small population, just a few over 10, 13 dogs with, they call it IBD, that we like to call it chronic enteropathy. These dogs were recruited and they were started on immunosuppressive treatment and what they call a hypoallergenic diet, meaning a hydrolyzed diet or a single novel protein diet. And they were randomized into receiving one single FMT by retention enema versus placebo. And what they weren't able to demonstrate by following these dogs at 7 and then 30 days later, a change in a statistical significant difference in the clinical activity index before and after the single FMT or the placebo administration, and no change in alpha and beta diversity. Okay, so in other words, it seems as if FMT is not superior to placebo in this population. But when you look at the paper, which I did because I was a little bit disappointed, then what you see, of course, we said it's a very underpowered study. So probably the chances of finding a statistical significant difference were already quite small. But when you look at the clinical activity index in the placebo and the FMT group, you'll notice that whilst the placebo group CHECI is basically the same from day 0 to day 30, the score of the FMT group goes from 6.2, the median score, to 1.78. So I'm wondering whether there might have been a statistical significance if we had more cases. And when you look at the graph of the progression of the clinical signs in these two groups, you can see how the dogs treated with placebo, in addition to steroids and hydrolyzed diet, remained symptomatic. It was a mild form of chronic enteropathy, as you can see from the median score, but you can definitely see that in the FMT group, there is a sharper decrease of the score. And by the way, 5 of the placebo dogs needed FMT because they were not responding to treatments. Okay, so I'm not entirely sure that this paper rule out the efficacy of FMT in chronic enteropathy. I don't know if you agree with me or not, but that's the only randomized controlled trial that we have. So when it comes to FMT, let's start to be practical about it. There's so many questions, so many doubts that we have about FMT and how FMT works. And many of these questions we don't have an answer for. I will try and answer some of these questions with a couple of publications, one of which we published. But you see, the major doubt is, when do we need to think about FMT, in the average chronic enteropathy case? Is it better to do it early on, or is it only useful when you have the non-responsive enteropathy cases? I don't know, what's your habit, what's your feel about? I know that many people think of FMT as a last resort. I will show you our study where we'll actually tested the efficacy of FMT way earlier in the disease progression, immediately after dietary trial. Okay, and the results were quite surprising. So I actually think there's a place for both scenarios. And what's the target? Because many people are disappointed when they see that the microbiota, the metabolome, hasn't shifted after FMT. But is that really the realistic goal in chronic enteropathy, in severe cases, late stages of chronic enteropathy? Probably not. Okay, so we should probably focus on clinical remission. But I will show you that if you use a clinically validated marker of the analysis of microbiota, you do see some positive shift after FMT. We will look at how long those positive changes last. Okay, but we do see some changes even in the metabolome. And how can we predict? Because that's a very important point. So you have a client, you're about to recommend FMT, client of a dog with chronic enteropathy. How can you anticipate what the response of that patient is going to be? And how many FMT you're likely to administer in order to achieve a positive response? These are all clinically relevant questions we need to answer, okay? And we will try to do that with a couple of papers. Okay, so here's the first paper. This is the paper we published in 2025. But this paper has 5 years in the making, because it was just about before COVID hit that I contacted the group of the University of Bologna with the idea of testing the efficacy of FMT in dogs, especially young dogs with mild disease, yet not responding to dietary trials. We see many of these cases that you're questioning whether you really need to do endoscopy or use steroids, because clinically they're not doing so badly, yet they're not responding to diet. Okay, so, and I remember when I asked Carla Vecchiato, she's a nutritionist from the University of Bologna, about the study, she had no idea about FMT. And her supervisor was very skeptical about the idea of doing this study. So the way we designed it, it was very hard to find, of course, dogs with chronic enteropathy didn't respond to diet. right? Because 75–80% of the cases we see will respond to diet. Okay, so that's already a hard ask. But you see, we identified 20 dogs, 10 in our hospital, 10 at the University of Bologna. And as you can see, criteria for inclusion was undergoing a dietary trial, either with a hydrolyzed diet, one of 3 hydrolyzed diets, or a home-cooked diet. Okay, but many of these dogs had already been tried with diets. You see, at least 1 to 2 previous dietary trials. So that makes it 3 dietary trials before being enrolled into the study. And we, as exclusion criteria, we didn't want any interference from antibiotics, recent antibiotics administration, and steroids administration. Okay, so they had to be free from drugs for at least 30 days before the enrollment. Are you with me? Okay, testing a hypothesis. So you see, once we enrolled these cases, we treated them with either 1 to 2 FMT through a retention enema. This was a decision made by the treating clinician. So it was mostly based on whether they were clinically better according to the owner. If they were not, they were treated with a second FMT, and after which we started the follow-up. Okay, so there was maximum 2 enemas. And we followed these cases up for 30, 60, and 90 days after the FMT. We collected, of course, clinical activity index. We looked at the fecal score. And then later on, we looked at the fecal dysbiosis index. We also did next-gen sequencing and targeted metabolomic. But of course, we didn't know the results of these tests. Okay, so we only had clinical available data. So the study lasted 30 days, but a year later, so before publishing the study, we called up these owners to see how these dogs were doing. Okay, so we also have some, let's say, retrospective long-term follow-up. Now, as I told you, we were aiming for those cases. So young dogs, so you see the average, the median age was quite low. Mildly affected, so you can see that the clinical activity score, the median score was quite low, 5. But you see, some of these dogs actually had severe depletion of serum cobalamin, so at least signs of malabsorption. And when you looked at the clinical signs, you will appreciate that the majority of the dogs had diarrhea, chronic diarrhea, but many dogs had actually clinical signs that were impactful for the owner, yet not included in the CBDI. And I know that this is an experience that many of us have, especially with small, stressy breeds that have repeated leaky fits and abdominal cramping, and yet they would have a normal CBDI because they don't have vomiting, they don't have diarrhea. So we also included these chronic enteropathic dogs. Now, an important data, because I will go back to this, is that although antibiotic use was an exclusion criteria, it was okay to receive antibiotics before 30 days. And we identified 7 dogs that had been treated up to 60 days before the enrollment with antimicrobial, mostly metronidazole and tylosine. Okay, so the antibiotics that vets use for chronic GI signs. So looking at the clinical response, the main target, we were quite amazed to see that 17 out of the 20 dogs achieved clinical remission based on the CBDI and also the fecal score up to the end of the monitoring, so up to time to T3. Okay, so that makes it a clinical response of 85%. Now, that would have been higher because one of the 3 dogs that we lost to follow up or we excluded from the study had responded to FMT, but he had to take antibiotics for a bacterial endocarditis. Okay, so we couldn't count him in, but that would have made it 18 out of 20. So quite amazing. As you can see, we already said this, the CBDI, the median CBDI was quite low, but still it decreased down to 1, and it remained so until 90 days. Now, when we called up these clients, we only had available follow-up, long-term follow-up, so 17 of these dogs. 10 of these dogs had no relapse of their clinical signs. So they were absolutely fine. And they were kept on the diets we've been trialing them on before FMT. So that's 60% of these cases, long-term remission. Now the remaining 7 did have a relapse from 6 months to 12 months, at least one relapse. But it was interesting to see that 5 of these cases were rescued with FMT again, which is one FMT, which is quite without the need of immunosuppressive treatment. Now, when we looked at these 2 groups, so the relapsing one and the not relapsing one, there was no difference in the clinical severity or the dysbiosis index at time 0. But I don't know whether you can see, I'm colorblind, but these dots should be red, meaning that all the dogs in the relapsing group were the dogs that had received antibiotics in their history. Okay, so, and this is an important statistical data. So when we looked at the fecal dysbiosis index that you heard today, it's a way of quickly and clinically assessing whether there is or not dysbiosis, because it tells us whether there is a shift of the overall microbiota from what's normal. A normal dog would have a dysbiosis index below 0. A dysbiotic dog will have an index above 0. And if it's above 2, that's a significant shift, okay? So a major shift. We were surprised to see later on that many of our dogs, actually 50%, had a normal dysbiosis index. So they were chronic enteropathic dogs with no evidence, clinical evidence of dysbiosis. And the other half, the other 50% of dogs actually were dysbiotic. And when we looked into this group, we saw that 6 out of these 10 dysbiotic dogs were the dogs that had received antibiotics 2 months before enrollment. And we know in healthy dogs, even short courses of antibiotic can actually induce lasting dysbiosis, okay? And now we know that this is true also in chronic enteropathic dogs. So when you select, although there was no statistically significant difference in the dysbiosis index from before and after the FMT, if we selected these dysbiotic dogs, indeed there was a difference from the other cases, and the dysbiosis index did drop after FMT with statistical significance. Okay, but still, we were surprised to see that not all dogs were dysbiotic. So, for whoever tells you that there's no point in testing for intestinal dysbiosis because all dogs with chronic enteropathy will be dysbiotic, the answer is it's not true. Okay, and the efficacy of FMT, we can gauge this information already, is not necessarily related to re-establishing the normal microbiota, because FMT is the postbiotics for excellence. Okay, it's a superbiotic. There's so many anti-inflammatory, immunomodulatory biotics in there besides, live bacteria. So when we looked specifically at Peptacetobacter rhamnosus, which is a very important part of the intestinal microbiota of dogs, and is also a core bacterium part of the dysbiosis index, there was no difference in the total abundance determined by qPCR before and after FMT. However, 6 dogs out of the 20 had a depleted Peptacetobacter rhamnosus, therefore high risk of a lack of secondary beneficial bile acids. And the majority of these dogs were in, again, antibiotic treated group. And all of those dogs from the antibiotic group returned to a normal abundance of rhamnosus after the FMT. Okay, and this is another clinically relevant information. FMT works very well in reestablishing eubiosis in dogs with antibiotic-induced dysbiosis. Okay, it's probably another important application for FMT. Of course, like we said earlier, when we looked at the alpha and beta diversity in these dogs, we were not able to separate them from healthy dogs. We had a group of 17 healthy dogs we had data of, and diseased dogs before and after FMT. But when we subcategorized the cases based on the severity of dysbiosis using the dysbiosis index, indeed, the dogs that had an index above 2, so significant dysbiosis, clustered together on next-gen sequencing, okay, so on beta diversity. And this is a concept that is very important, okay? There are 2 types of chronic enteropathy, probably 2 stages, the dysbiotic and the non-dysbiotic, the early stages and the late stages. And the response to treatment would likely vary, including FMT. So from a metabolic standpoint, there was no difference before and after FMT in short-chain fatty acids, but we did find a difference in primary and secondary bile acids before and after FMT up to 30 days. Specifically, we had an increase by 60% almost of a decrease, of primary bile acids and an increase of 40% in secondary bile acids, beneficial immunomodulatory. And indeed, this was linked to the abundance of Peptacetobacter iranonis, okay? So he's the marker we interested in. So the conclusion for our study, for me, clinically useful relevance are the FMT, it's effective as a primary treatment strategy in dogs with dietary refractory chronic enteropathy associated with mild intestinal microbial perturbations, and a long-term response is a achievable target, especially younger dogs and dogs with mild clinical disease, okay? I would also add dogs with previous antibiotic treatment. So look for these hints into the history is my advice. Therefore, I think FMT can actually be applied in the pyramid of sequential treatment trials, to characterize the phenotype of chronic enteropathy, exactly like Juan also hypothesized straight after diet, okay, ahead of steroids in this population of dogs. Okay, so for me, this is a useful information. But then there is the other population, right? The other application. We said adjunctive treatments in those late stages, refractory or non-responsive enteropathy, like they like to call them, okay? Which is another important application. And this is another really useful publication because it's another prospective study from Linda Torresson, so from Sweden, where she actually tested the efficacy of repeated fecal microbiota transplantation in dogs with partially responsive, steroid-responsive enteropathy or non-responsive enteropathy. She actually had the idea from her first paper, which was a retrospective study, with more or less the same number of dogs, so around 40 dogs with this phenotype, that responded. You see 72% of these dogs in this study responded to up to 3 FMT, a median of 3 fecal microbiota transplantation. Again, by retention enema. And in some of these dogs, a good proportion, the clinical response was sustained for more than three months. Okay, but it was a retrospective study. However, from this study, there was an interesting finding, which is quite repeatable and consistent. And I will show you a clinical case example later on, is that when you look at the dysbiosis, as expressed by dysbiosis index, in the dogs that will benefit from FMT versus those that don't benefit from FMT, you notice that there's a significant difference, okay? So the more severe the dysbiosis, the more likely the later stage the disease, the less likely to respond to FMT, okay? But then she tested this finding with a prospective study. So she selected again almost 40, in 5 years, 40 dogs with, again, long-standing chronic enteropathy. You see from different breeds, Labradors were overrepresented, but different breeds. You see the majority were receiving immunosuppressive treatment to control the clinical signs, but there were no in remission. And so that was probably 3/4 of this population. And the remaining quarter was dogs that were with progressive disease, okay? So not showing any response whatsoever. And when you look at the duration of treatment, it was quite striking, you see, up to several years. Okay, so this is what I said earlier on. Late stage, advanced cases. And another important data is that many of these dogs had already been trialed on diets. This is an important information we now passing across to clinicians and vets alike, is that you have to try several dietary trials before you can label a dog with chronic enteropathy as non-food responsive. And in this study they did, because the median number of dietary trials was 4, okay? That's definitely more than the average number of dietary trials. So you see, regarding medical treatments, mostly steroids, but look how many dogs were receiving 2 immunosuppressive medications, okay? Which is not very typical in my experience for, you know, the average chronic enteropathic dog. And few dogs had received antibiotic. Now, I'm not Swedish, but I know that in Sweden you cannot prescribe antibiotics. So if they did in those 6 cases, it meant that, you know, those dogs were really doing poorly, because in Sweden it's illegal to prescribe antibiotic for GI signs. Okay, so just to show you how severe the signs were in these dogs. And you see, the majority of the reasons for trying FMT was diarrhea, but in some dogs was poor appetite, and in some other dogs was the inability of stopping the immunosuppressive treatments, which come, as you know, with quite severe side effects. Okay, so there are several layers to the efficacy of FMT. It's not just about the gastrointestinal signs. So you see, 33 dogs received 3 FMTs, which meant that they showed some initial response, so that they continued within the first month or so. The remaining 6 dogs didn't go above 2 FMTs because they didn't show a response beyond 7 days. Okay, so they were labeled as non-responders, so they stopped after the second FMT. And when we looked at the overall clinical improvement, the rate of improvement was 72%, meaning 28 dogs out of 39 improved. When they looked at the duration of responsiveness, the majority of these cases, 20, were in remission or had a positive clinical response beyond 3 months. Many of those actually beyond six months as well. But the cutoff was 12 weeks. Some dogs, 8 dogs specifically, had a response but relapsed after a month and a half, and then the remaining 11 didn't show a response beyond 7 days. So they were labeled as non-responder. And when they characterized the clinical response, the majority of these dogs had increased activity level, so increased demeanor, which is let's call it a side effect of successful FMT. But in my experience, we see it a lot. Clients that tell us it's like having a new puppy after the FMT, irrespectively of how the GI signs are doing. Okay, I don't know whether for those who do FMT, use FMT, whether you also have this feedback from the owners. And you know about what we know now about the interaction of the brain and the gut and its axis. But you see, of course, many dogs had an improved fecal consistency, and dogs that were underweight had a weight gain. Okay, so again, there are several layers to the response, and 30% of these partially steroid responsive dogs were able to reduce the dose of steroids, or even, that was just for 2 dogs, discontinue it. Okay, and this is something that I see in practice as well, and it's something quite useful, being able to discontinue drugs with high side effects. So when we looked at the clinical data, so the clinical variable, so the CBDI, you could see that from time 0 to time 1 in the overall population, there was a statistically significant drop in the median CBDI. When they looked at the clinical severity between the long time responders and the short to non-time responders, there was no difference on the severity of clinical presentation, meaning you cannot decide whether they're going to respond or not based on how severe the presentation is. Of course, these are the non-responders. You can see the CBDI didn't change from before to after the FMT. This is the CBDI in the responders. And this is the response in terms of CBDI across time. As you can see, the median CBDI dropped and stayed below the clinically significant disease up to 6 months. Okay, so that's a sustained clinical response in a severe phenotype. Okay, severe phenotype of disease. When they looked at the dysbiosis index, they confirmed a statistically significant difference between responders and non-responders in terms of a baseline dysbiosis, the severity of dysbiosis. Okay, so the median dysbiosis index was significantly lower in the responders compared to the non-responders. And as you can see, many dogs in this population, probably also because of the medical treatments, were mildly dysbiotic or non-dysbiotic. We're talking about non-responsive cases, okay? So be mindful of the fact that you cannot predict dysbiosis just by suspecting chronic enteropathy. This is the dysbiosis index over time, and you can see the statistically significance of the decrease up to 6 months. Again, just to stress this important clinically applicable data, if you look at the severity of dysbiosis in the responding population, almost 80% of these dogs were either eubiotic based on dysbiosis index or had a mild dysbiosis. In the non-responder, 70% had severe dysbiosis. Okay, I would still try FMT, but you can use this predictable information with the owner. Okay. Now, when they looked at the fecal unconjugated secondary bile acids between groups at time 0, you could see that, of course, in the non-responding group, which had a more severe dysbiosis, the secondary bile acids were much lower relatively to the total bile acids. And 1 month after, in the long-term responders, the percentage of secondary bile acids went up to almost normal, what you would see in normal dogs, unlike in the non-responder. And I just want to point it out that more than 50% of the long-term responder that had extremely low secondary bile acids at baseline had bile acids within the normal percentage. Okay, so this is a demonstration of positive metabolic response. So the conclusions I take from the study from Linda, which is also what I see in my practice, is that you can consider FMT in those late stages, okay? So those partially responsive to non-responsive cases. The severity of dysbiosis and the degree of bile acid dysmetabolism will predict whether the dogs will respond or not, okay? So again, linked to the severity of the microbial shift. And then in this population is probably realistic and expectable to repeat FMT over time, okay? Which we're very happy to do when we're prescribing steroids, you know, long-term steroid treatment, no discussion about it. But when it comes to FMT, we drop, you know, we stop, we lose heart if 1 FMT doesn't work or 2 FMT doesn't work. This is, again, clinically relevant information. In the right cases, you have to insist, okay? So likely repeat and repeat again when they relapse, okay? So I want to show you one of the explicative cases, okay? Because I have so many since we published the paper. And so this is a beautiful Alaskan Malamute, actually quite young. Beautiful, honestly. Not when I saw him, it was quite run down, but it became beautiful afterwards. You see, he had been okay, typically having GI upset, typical history, but fine with probiotic or a dietary change. But over time, he started to have chronic diarrhea, which was unresponsive to this symptomatic treatment. Therefore, the referring vet was actually a nutritionist. Okay, a boarded nutritionist, tried several options, including commercial hydrolyzed protein diet and home-cooked diet with no response. Therefore, following the traditional pyramid, they were very good. They bypassed antibiotics altogether. okay? But they reached for endoscopy histopathology, which indeed showed mild to moderate inflammation. So therefore, they prescribed glucocorticoids to a 50-kilo young Alaskan Malamute. And, you know, irrespectively of the fact that he didn't respond, he developed, I'll show you in a second, very severe side effect for glucocorticoids. He was labeled as a non-responsive chronic enteropathy. Don't know what to do. Go to Portoni Rossi, okay, because they'll try something. So imagine a 50-kilo dog defecating up to 7 times a day, this, okay? So quite severe. It was mostly large intestinal diarrhea, but what was more worrisome for me was the development of hyporexia to the point of anorexia and the severe polyuria, polydipsia, exercise intolerance due to the steroids, chronic steroid use. So what we do, and this is something I want to stress for who's on clinics, and it's very important, we stage the patient, okay? So when we visit the patient, we do laboratory diagnostics, we try to gauge how severe the disease is, okay? And we do that with the clinical activity score, which was quite high when we saw him. We use laboratory tests, which were okay, and we use diagnostic imaging and also some marker of intestinal damage or malabsorption. They were all okay, except for, of course, signs of steroid toxicity. And so what we decided to do was to start an initial plan to wean him off the steroids because he was probably going to be killed by the glucocorticoid toxicity. We chose a diet like Arti told us, right, with a good dietary history that he'd never tried before, with some reasoning, for example, fiber enrichment, the type of diarrhea Skoll had. We tapered and discontinued the steroids, and we continued the probiotic he was receiving. Although I share the doubts that some of you, I would say 50% of the audience had, about the evidence of efficacy of probiotics in these severe cases, right? I was one of the voters that said low, but I used them. And so it was surprising to see that just by discontinuing glucocorticoids, he actually showed a clinical response. So the owner was absolutely ecstatic. But of course, he wasn't in complete clinical remission, okay? So the delta of this CBDI, especially the fecal score, was not adequate. Now, when we had this, the owner was so happy. She was like, "You are a genius." And no, Beatrice is laughing because she probably remembers this lady. "You are a genius." But I wasn't happy. I was like, oh. And so we decided to send the dysbiosis index because we wanted to see whether he was severely dysbiotic and whether there could be something more that we could do. And indeed, because she was so happy, we waited for several months, waiting for the situation to change. And what I want to point out that is this dysbiosis index didn't change in the space of 6 months. So it remained above 2, indicating a major shift in Skoll's intestinal microbiota. And what you see is that in September, so 6 months after we saw him, he developed a drop in Peptacetobacter ranonis abundance, and that's metabolically relevant, okay? Meaning he could have an accumulation of primary bile acids as a component to his clinical signs, what we call bile acid diarrhea, or anyway, like an inflammatory stimulus due to a lack of conversion of primary and secondary bile acids. So we decided to perform some FMT. I mean, it was challenging because how donor, you'll see her in a second, she was probably she is half the size of Skoll. And so he needed a lot of poo. So we decided I will show you how we separated the FMT. But overall, he had 4 treatments. Now, for me, that means 4 FMTs, that means 2 treatments, because we also believe in repeating FMTs within a short period of time. And his clinical signs improved even further. Okay, so for the first time, the owner said, okay, now it's perfect. I was happy before, now it's perfect. Okay, so I'm going to ask you now, what's the dysbiosis index of score going to look like? Is it going to be 2? So abnormal? Is it going to be normal? And is it going to be normal, abnormal after the first cycle of FMT or after the second? You don't know because you can't tell. That's the thing. You cannot predict. So I'm going to show you what happened. Okay. So in September we did the first 2 FMTs. It's an expensive, relatively expensive test, the dysbiosis index. So you have to choose on repeating or not, and when, also based on the owner availability. So we'll let a few months go by, even because it was doing really well. So in December we had the results of his post-FMT dysbiosis index. He hadn't moved. Okay. And so we decided to treat him again, but remember that he was clinically normal. Okay. So he was fine. And then you see 2 months after the second round of treatment, his index dropped to -5, which is what you typically see in donors. Okay, so it's like a really, and the Iranonis was back to normal. But my question is to you, now you should know the answer based on what I showed you. Is he going to stay in remission, or is he going to relapse? What do you think? Remission, raise your hand. Like long-term remission. A few optimistics in the audience, I like it. And so the remaining doubtful, or you think is going to relapse? I think it's going to relapse based on what all the data that we now have on the predictability of relapse based on the baseline dysbiosis index and metabolic shifts. And he relapsed. He relapsed several times. But the good news is that we rescued him every time with FMT. Okay, so and he's now probably, I don't know how old is he, and he's still going with his FMT. So I'm basically finishing, and slightly late, I don't know. Just to remind you that I had the honor of taking part into this beautiful effort, amazing effort. It took us 1.5 years, together with 21 other people that are interested or had experience, or they were researching FMT from 19 different countries. Okay, several different continents. So this is just to show. We actually looked at the available evidence to produce some clinical guidance for general practitioner, okay, on 3 aspects: donor screening and selection, FMT preparation, and clinical applicability. And they are open access, and you can find all the technical details, okay? Because I'm sure many of you, especially the students, will be curious to know how you actually do a transplant. And bear in mind that some clients might actually ask you whether you're going to open the abdominal cavity if you say transplant. So it happened to me a couple of times. And now, just as a last slide, before your questions, if you have any, I just want to show you this exchange of love cards between my first FMT treated case, Ghibli. You never forget the first one. He's a young German Shepherd, of course, with a history of antibiotic treatments and then non-responsive enteropathy. He was the first case I treated. The owner came from Milan to see me. I'd never done it, but I've been started to talk about FMT in Italy, and she wanted FMT. So we gave one enema, one retention enema. He was fixed. He's in remission now. Okay. So less likely to be a true non-responsive enteropathy, more likely to be antibiotic-induced dysbiosis, because he had received many antibiotics. And this is Kira, our donor. She is still the donor. Okay, so we decided to stick to one donor. She's been serving now for 5 years, and she's getting near to the age of retirement. I'm already feeling emotional because she donated several times and treated and helped hundreds of cases. Okay, and that's it for me. So I hopefully kept you awake a little bit. Thank you so much.